I'm Dr. Oliver Bernath. I'm the Managing Director and founder of Integrated Health Partners. We are a company that works with GPs to really take hold of the overall budget as a provider organization and to manage care pathways across the entire length of the pathway. I'm a doctor by background, a neurologist. I trained in this country but also in the United States, and my last job over there was at Kaiser in San Francisco, where I headed the sleep lab and epilepsy center in San Francisco.
Oliver, what do you think the implications of the white paper are to the NHS?
I mean, the white paper is often being criticized as being pretty white, but I think I would not have expected a strategic document like the white paper to go into operational details. Where it is very clear is what the overall goal of the whole reform is, if you so will, and that is bringing together clinical decision making with financial accountability and marry them up. And that, I think, is overall very clear. And how now the operational details work has been explored in the consultation over the last few months, and I think that the health bill that should come out in a couple of months or so will answer a lot of those details. Now, I think the white paper has triggered lots of waves of being very revolutionary, the biggest change of the NHS since 1948. If I look back to policy development over the last 10 years, I think it's a logical next step in a sequence of things, starting with splitting the NHS into a payer and provider function rather than having a monopolist situation, I think drives into that direction. And in a sense, the practice-based commissioning policy is a direct precursor of that. The integrated care organization pilots under the last government is a precursor to that. And so what it feels new and maybe revolutionary is the speed and the depth of this change, which is driven again by the financial crisis and by lack of speed beforehand. But I don't see anything fundamentally new, and it is something that all the doctors and GPs have been asking for the last 10 years. Now we have it on the platter, so let's get on with it.
Can you tell me what the best structure is for a GP commissioning body to be?
To be honest, I think the commissioning body is actually the wrong discussion. I think there will be national legislation. I think the GP commissioning consortia will be statutory bodies, and thereby the whole terms of legal entity and all the rest of it is a discussion. It's something we'll take as it's necessary from what it has to be, so I think that's not really a big discussion. I think much more interesting is the discussion what's the other organization that you actually need in order to make this commissioning part work. If I just reflect back on the commissioning part, you get a bit sort of a one-sided bet as a GP. You be given a budget and now you have to stay within that. I don't know whether you'll be given more powers than a PCT, who has found it very difficult to rein in hospital spend, so how you do it as a GP, I don't know. And if you overspend, the white paper says you won't get a bailout. Now it doesn't spell out exactly what that is, but I hear that GP personal income would be at risk to some extent through QOF points, where I'm sure there will be a QOF point, excellence in commissioning, and if you overspend, that one goes away. You will not be asked to pay into the pot for overspend. However, I think that GP practices and consortia will lose the right to commission if they overspend consistently, and that would potentially put a practice in its very existence at risk because you lose a list, basically. So that's a fairly large stick. However, there's no carrot with it, and I'm not so sure how much power is there actually to make overspend risk go down. That's why I think there's another side of the equation that's more sort of the provider side of the GP world, and I think that should be also intrinsically much more attractive to GPs that are doctors, after all, that went to medical school to look after patients rather than being commissioning experts. And that is, call it integrated care organization, call it managed care organization, but basically an organization that's the mirror image of the commissioning consortium, that is a provider entity amongst the GPs, which then could take on the budget as a lead provider contract, thereby creating a situation that for the GPs, the risk has been given from the commissioning side to the provider side. And secondly, you also now create a commercially viable model where if you create a margin out of delivering the outcomes as commissioned at a fair price that is market tested and regulated, and you create a margin in there, then obviously you have got funding to drive the initiatives that you need to do to contain costs. The second opportunity on this lead provider managed care organization is that you can bind in all other providers of care, like the community services and the local hospitals and any willing providers, into something I would call an alliance, with an alliance contract where you are jointly responsible for staying within budget, potentially also sharing the underspend as an incentive. If you do that, then you don't really have any leak of costs going anywhere, because if all providers in the market collaborate to stay within budget, well, there's no money going anywhere else. So thereby you actually have contained the risk. And I think that's the crucial element that will bring control to the overspend that you cannot deliver through just a commissioning body.
Oliver, what do you think is the optimum number of patients that a GP commissioning body should hold?
Optimum number of patients in a consortium has been a much discussed question. I think there will have to be a practical answer. I don't think the BMA's view of having 500,000 or so is feasible, because you start losing the local touch, and I think the consortium has to be practices that know each other and can operationally work together and also share a risk. So I think, in my view, it will go that you have local consortia that may be as small as 30,000, 40,000 patients, depends on geography. Some rural areas we probably won't have much more to form a cluster, up to maybe 100,000, 150,000 patients, or 10 practices or something like that. And then I think the consortia then will have to form an umbrella network that can come together when it is about negotiating with the local hospital, so they are, as a local health economy, one voice towards the hospital, and also where they can share potentially overspend risk in a larger pool. But I think it will be a two-level, one local down to fairly small to something slightly larger.
If we move on to the difficult question of PCT budgets and the new commissioning budgets, how do you think the new commissioning bodies are going to manage having a third of the budget that PCTs currently hold? Now, not all functions of the PCT will be given to the commissioning consortia. So, for example, public health goes to the local authorities. So you don't quite need the same whole budget. Also, as far as I understand, the GP consortia will not be looking after the NHS real estate and facilities. Where that lands, I don't know yet, but I understand it's under discussion, but that's not what you will have to manage. So thereby it's fine to have a smaller management budget. I do agree that the rumored £10 are probably fairly tight. And then the question is, how do you do that? I think there are some opportunities that high volume transactional work that is right now done by every PCT probably can be consolidated to, I don't know, 3 national processing centers, and thereby achieve higher efficiencies. And I also do think that removing quite a lot of the target-driven performance measurements that really only generate reports and nobody acts upon, you can drop without losing anything. So I think being forced into a much smaller management allowance, you are forced to really make sure that what you do as a management function actually does impact what you do on a clinical provider side. Right now that has been a bit too loose, so I'm looking forward to having a tighter budget. Even less would be even better, I think, to just make sure it becomes efficient and meaningful. A lot of GPs are concerned about the legacy debts they may be faced with when they take over the functions of the PCT. What are your views about legacy debts? Practically, I think what a GP consortium has to aim at is to use the next 2 years to get into a position that once they take over the budget, for sure in the first year they will not fail. So if they're right now on a trajectory downwards into the black hole, then they have to make sure that they're at least on a even keel at the very least. Ideally over the next 2 years also contribute to getting the depth of the hole smaller. If there's still some debt left of significant size, I think there will have to be a transition arrangement that makes sure that the GP consortium can start, and maybe there will be a time period over which you'll be able to repay the debt. So that is something for the negotiation, but the target for the GPs should be to reach a run rate that is sustainable and break even in 2 years' time. Oliver, what do you think will happen to practices who may not be able to control their budgets? Do you think there's a possibility they may be expelled from a consortium? So what happens to overspending practices, in particular in areas where you have maybe an elderly population, well-educated middle class typically, that know their rights and are more demanding for healthcare? There are always two sides to the equation. One is, has the budget been set properly? And secondly, are you tight enough on controlling spending? We have a situation where we work with practices that are amongst the cheapest per capita compared to others, and yet they're overspent dramatically because their budget is one of the lowest, driven by the demographics. So I think there has to be some review of reflecting the actual cost of provision to budget allocation. The current system, I think, doesn't really reflect that. And the second part is still making sure that you really become very efficient in controlling spend.
Now, I think the role of the consortia will be to mitigate some of that. If a practice still is underperforming and overspending and is really not participating in what the initiatives of the consortium are, then I think there has to be the right to expel such a practice from the group. However, I do assume that the budget allocated to that patient population stays within the consortium. Now the question arises, what happens to that GP practice without a budget for its patients? And that, I think, is a real threat for the GP practice, that it's actually not a GP practice anymore. It probably is a group of doctors that can work on contract to others in the consortium. And that means either other practices take over that budget, or other larger independent primary care provider groups may emerge that start bidding for those expelled practice populations.
If you take more for one practice, it means less from another practice, would it not?
Yeah, so internal mitigation of budget shortfalls within a group. I mean, some of that mitigation obviously will have to cover random variation. In one year, the one practice was unfortunate enough to have a few expensive patients, and the other year that will be another practice. So some of that will just be evening out random noise. If there's a structural problem with the allocation of budget and the spend of the practice, then obviously the whole allocation will have to be reviewed. And I think that's sort of, for me, one of the biggest questions over the next few years, how healthcare money is being allocated to different areas. And it may well be, and that's sort of the radical end of it, that populations that are very good at knowing what access to healthcare they should have under the NHS have to learn that maybe the access will have to be restricted simply because of affordability. That's politically unpalatable, but ultimately the truth of the story once the budget becomes too tight. Having said that, I think there are huge savings opportunities within the NHS and improved service at the same time. So I think it would be unjustified within the next few years to tell patients that they can't have services that they should have. I think for us as doctors and as management of healthcare, it is really for us to show that we can create efficiency, and I think we should live up to the challenge.